BCMA-targeted therapies are bringing through major changes in the treatment landscape for multiple myeloma. Currently, we have available bispecific T-cell engagers, antibody-drug conjugates, and CAR T-cell therapy. And one of the issues that we face is how to choose the correct treatment for the correct patient. What we know is that bispecific antibodies have higher response rates compared to Belantamab, but the side effect profile is very different. So the aims of this study was to try and understand the differences between these two modalities from a toxicity standpoint. What we looked at was our own institutional data, and we found that patients with Belantamab were older and frailer compared to the patients who received bispecific antibodies. We also saw that the nadir of IgG levels was lower with bispecific antibodies compared to Belantamab. And we also found that we were using more intravenous immunoglobulin for bispecifics, so that's 40% in total compared to just 2 to 4% with Belantamab mafodotin. The overall incidence of infections was 2.5 times greater with bispecific antibodies compared to Belantamab, and was predominantly respiratory infections as well as some urinary tract and blood-borne infections. What we found was that despite giving intravenous immunoglobulin, a further 30% of patients continued to get infections with the bispecifics, and these were predominantly viral infections that occurred. So overall, what we see is that whilst bispecific antibodies have higher response rates, that the infection rate is much higher, and you need higher levels of intravenous immunoglobulins to try and limit that. We also looked at viral PCR monitoring in the blood, and whilst we saw a number of reactivations, they were predominantly asymptomatic. And so the actual symptomatic viral reactivations in terms of CMV was very low, and it's still yet to be determined whether routine viral PCR monitoring is required.